The next type of language disorder is a pragmatics disorder. Now, pragmatics disorder may be where the child has difficulty with the social rules of conversation. The child doesn't know how to open a conversation or close the conversation. The child is unable to maintain the topic, so as you're talking, the child is constantly switching topics, but you don't know that the topic has been switched. The child doesn't reference pronouns, so you really don't know who or what he's talking about, and the child doesn't have an understanding of presuppositions. In other words, he assumes that you know a lot more than what you do. Pragmatics disorders can also involve having difficulty with the communicative intent of a sentence. So, for example, when we say, "Could you please pass the salt?" we're really not asking a question, we're saying, "Pass the salt." If we say, "You've got the cart before the horse," we're really not talking about a cart or a horse. There's an underlying meaning to that, and a lot of kids have major difficulties understanding that. And it may be even more subtle. It may just involve intonation. So if I said to you, "Well, that's just fine," I'm really not saying it's fine. I'm saying it's not fine. So kids who have pragmatics disorders have difficulty with a lot of these things. I remember one time working with a child who told me that he'd gotten in trouble at school and was sent to the principal. When I asked him why, he said, "Well, I came in to talk to my teacher and I said, 'Hey babe, how was your weekend?' And she got really mad at me." And the problem was he didn't understand that that wasn't an appropriate use of language in that particular situation. He heard his dad come home and say that to his mom, but it's not appropriate for a child to say that to the teacher. So this all involves pragmatics. There are various causes of language disorders. One is sensory deprivation. It could be hearing or vision. Another would be a cognitive disorder, which usually involves developmental delay as well. Cerebral injury or dysfunction, and finally, environmental deprivation. Now let's talk about phonation disorders. A phonation disorder may include abnormality in the quality of the phonation. This might involve hoarseness, breathiness, or glottal fry. A glottal fry is a low-frequency vibration that sort of sounds like this. And so in the voice, you can hear this low frequency vibration that can be really hard to listen to after a while. The other thing that may happen is that there may be an abnormality in the pitch. The pitch may be too high or too low for the child's age or sex. And finally, there may be a problem with intensity. Sometimes we find kids who are too loud, but more commonly we find that the child has difficulty increasing volume appropriately. There are various causes of phonation disorders. The most common cause in children is vocal nodules, but anything else that affects the structure of the vocal folds or the movement of the vocal folds can cause a phonation disorder. Another disorder that we commonly see in kids is a resonance disorder. The resonance disorder may include hyponasality, which is not enough sound resonating in the nasal cavity during speech. Hyponasality sounds like this. It sounds as if the child doesn't have enough sound in the nasal cavity and is all stopped up. The next type of resonance disorder is hypernasality. Hypernasality sounds like this. There's too much sound in the nasal cavity during speech and not enough sound in the oral cavity. And then cul-de-sac resonance is a little tricky. Cul-de-sac resonance occurs when the sound is blocked in either the oral cavity, the pharyngeal cavity, or the nasal cavity. In fact, the cul-de-sac nasality sounds like this. It sounds muffled, and it sounds like it's low in volume. There are various causes of hyponasality, from nasal congestion to a deviated septum, stenotic nares. Anything that causes a blockage in the nasal cavity can cause hyponasality. Hypernasality is usually caused by a form of velopharyngeal dysfunction and is often secondary to a history of cleft palate. But there are other causes of hypernasality as well. And again, cul-de-sac resonance is when the sound is stuck and it can't get out due to a blockage. So sound resonates in the pharynx or the nasal cavity or even in the oral cavity, and as a result, the sound can't get out and it sounds muffled and low in volume. One form of cul-de-sac resonance has been called potato in the mouth speech. I think potato in the mouth speech is a really good description of the type of cul-de-sac resonance that we find when there are enlarged tonsils. What happens with enlarged tonsils is that they can block the transmission of sound into the oral cavity. As a result, sound resonates in the pharynx, and a lot of the sound is absorbed by the tissues, making it low in volume. I think it's important to note that the evaluation and treatment of voice disorders really requires close collaboration between an otolaryngologist and a speech-language pathologist. The team approach is usually in the best interest of the patient for both evaluation and the treatment of these disorders. The last disorder that we'll talk about is a fluency disorder, often called stuttering. Stuttering occurs when speech includes an abnormal number of repetitions or prolongations or hesitations or blocks in the normal rhythm or fluency of speech. One thing that we commonly see with a fluency disorder is that the patient or the child demonstrates a great deal of tension during speech, and there may even be secondary characteristics such as batting the eyes or closing the eyes or moving the head during speech. In talking about stuttering, I think it's important to note that children between the ages of 2 and 4 are very disfluent, and they're much more disfluent than adults. It's not uncommon for a child to run into his mom and say, "Mommy, mommy, mommy, guess what happened to me today?" And we would consider that perfectly normal. In fact, disfluencies are also very common with the adult speaker. It's been estimated that about 6% of the speech of a normal speaking adult is disfluent. The difference between a person who stutters and a normal speaker is the type and the amount of disfluencies. We don't have all the answers as to why some people develop stuttering and other people just have normal disfluencies. We do know that genetics plays a part and that some people have a genetic predisposition to developing stuttering. We also know that there's some neurological factors that can influence the development of stuttering. However, there's some environmental stressors that can increase the disfluencies in the speech of a normal speaker as well as a person who struggles with stuttering. These factors may include anxiety, nervousness, stress, fatigue, emotional distress, self-consciousness, trying not to stutter, and even a pressure to perform. One example would be that as a normal speaker, if somebody came in to me and said, "Ann, your son was hit by a car and he's severely injured," I might say, "Well, where is he? And what should I do?" And you would know from my speech that I was really distressed. So these kinds of things are normal. They're just magnified in the person who has a problem with stuttering. One thing that's interesting to note is that no matter how severely a person stutters, they never stutter in talking to a baby, talking to a dog, talking to themselves, or when they sing. The environment and the stressors in the environment really play a big part in causing the person to be more disfluent. Referral guidelines for stuttering are a little bit different than other speech disorders. In very young children, between the ages of 2 and 4, we would expect a lot of disfluencies. The reason for this is that the child is developing the ability to put words together for sentences and also developing the oral motor skills to provide different speech sounds or to produce different speech sounds. So speech is difficult, and they're also very excitable. However, it is important that if the child has been stuttering for a period of time, more than 6 months, and is over the age of 3, that child should be referred for an evaluation. In addition, if the parents are concerned or the child expresses concern or frustration, the child should be referred for speech evaluation. There are a lot of risk factors for developing a communication disorder. Oral anomalies are commonly associated with problems with speech production. Pharyngeal anomalies are commonly associated with resonance disorders. Laryngeal anomalies can be associated with phonation disorders. Oral motor dysfunction is a very common cause of speech sound disorders. Auditory problems can cause language problems or speech sound disorders. Different causes of neurologic dysfunction can affect articulation or speech sound production, language, phonation, and even resonance. Developmental or psychiatric problems can affect language and, in some cases, speech sound production. Environmental deprivation can result in significant language problems. Finally, let's talk about the importance of early intervention. If the child is showing signs of a speech and/or language delay or speech and/or language disorder, it's very important to intervene as soon as possible. There are several reasons for that. The first is that we want to take advantage of the time that the brain is very plastic for developing speech and language skills. There's a very critical period of development, and that's usually under the age of 3 and maybe up to the age of 6. The second reason that early intervention is important is that we want to avoid habit strength. The longer the child has been producing sounds incorrectly or putting words together incorrectly, the harder that habit is to break. The third reason that early intervention is important is that we want to avoid the effect of a communication disorder on social and emotional development. And finally, we want to make sure that the child has good communication skills before entering school so that a communication disorder does not impact the ability to learn or the child's school performance. One rule of thumb is, when in doubt, refer the child for intervention. Our goal in speech pathology is to help the child have age-appropriate communication skills by the time the child enters kindergarten. Thank you very much for your attention.